source is a allelon layer of food grains, and the thumb rule is to consume whole foods to avoid deficiency. The more intake of carbohydrates, the more intake is necessary of vitamin B1, and the RDA is 1 to 1.5 mg per day. These are the deficiencies which we're going to look forward now. It's the wet beriberi related to the cardiovascular diseases. It causes severe edema in the legs, face, and the trunk region. It causes severe breathing difficulty and can rapidly progress to high output cardiac failure, and death in extreme cases. Then to dry beriberi, which is related to nervous system, and it causes peripheral nephropathy and severe muscle wasting. The person will have difficulty in walking, a progressive loss of coordination, and in advanced stages to complete paralysis. Then infantile beriberi, it occurs in infants breastfeeded by mothers who are vitamin B1 deficient. And the key symptoms here are extreme restlessness, sleeplessness, irritability, and can lead to cardiac and respiratory distress syndrome if not treated. This is Wernicke-Korsakoff syndrome. It's cerebral beriberi is the other name. The common symptoms here are oculomotor dysfunction, confusion, and gait ataxia. Gait ataxia means the person gets the lack of coordination and wider gaits, and in severe cases it progresses to Wernicke-Korsakoff psychosis. The person makes up stuff to fill up the gaps in his mind. This is the difference between the brain of normal and Wernicke-Korsakoff syndrome's brain. And for diagnosis, we use erythrocyte transketolase activity is the primary marker. Thiamine levels decrease, pyruvate and alpha ketoglutarate elevate, and lactic acid drastically increase. The main causes of deficiency is chronic alcoholism, poor dietary intake through food by consuming highly polished food, and in case of increased metabolic demand such as hyperthyroidism, chronic illnesses, and etc. So vitamin B2, riboflavin. It's essential for energy metabolism, mitochondrial function, and cellular respiration. Serves as a precursor of coenzyme FMN and FAD. Its main sources are liver, dried yeast, eggs, milk, whole cereals and legumes, fish, green leafy vegetables. The daily RDA is 1.5 mg per day. Like B1, it is also proportional to the diet we consume. Requirements significantly increases during pregnancy, old age, and stress. Deficiency manifestations is the Ariboflavinosis, which has the following symptoms: it's glossitis, cheiliosis, angular stomatitis, corneal vascularization, seborrheic dermatitis. So these are the images which need to be considered for considering this disease. And the causes of the disease is mainly due to inadequate diet, malabsorption syndrome because there is a damage in the lining of the intestines, so the vitamin is not absorbed properly, and endocrine abnormalities such as severe hyperthyroidism. Diagnosis are erythrocyte glutamine peroxidase activity coefficient, e.g. RAC. It's the primary marker which is used, and urinary riboflavin is the next one. And vitamin B3, I'm giving it to roll number 80, Aishwarya Patil.
Another name is Pellagra preventing factor of Goldberger. It is not a true vitamin because it can be partially synthesized in the body from tryptophan. Active form is niacinamide, which is present in tissue. Biochemical functions, acts as a coenzyme in redox reaction and is essential in carbohydrate, lipid and protein metabolism. Coenzyme form is NAD plus and NADP plus. Sources are dried yeast, liver, peanut, whole cereals, legumes, meat and fish. RDA 20 milligram per day. During lactation is increased by 5 milligram per day. Deficiency manifestation. Pellagra, which is characterized by 4 Ds. First is dermatitis. Bright red erythema seen in sun-exposed areas like ankle, feet, face. Then hyperpigmentation at neck is Cazel's necklace, and at nails are irregular ridges. Second is diarrhea. Persistent watery diarrhea, which may be associated with blood and mucus in severe cases. Dementia develops in chronic cases characterized by irritation, inability to concentration, and poor memory. Death in prolonged untreated state. Causes of deficiency. First is dietary deficiency of tryptophan. Second is people who eat maize as a staple diet. Niacin is present but in bound form. Third is deficient synthesis of kynurenase, which is a pyridoxal B6 dependent enzyme. Huh? Okay. Fourth one is drug like antitubercle drugs. Fifth is Carcinoid syndrome, excess usage of tyrosine. This cause lack of availability of niacin. So next is vitamin B5, pantothenic acid, is widely distributed in both plants and animal foods. Biochemical functions, acts as a component of coenzyme A and acyl carrier protein. Required for synthesis of steroid hormones, acetylcholine and heme synthesis, essential for metabolism of carbohydrates, lipid and protein. RDA is 10 mg per day. Sources are eggs, yeast, liver, meat and milk.
Sir, should I restart or can I continue? So it's vitamin B5. Vitamin B5 is another name is pantothenic acid, and it's widely distributed in plants and animals. Biochemical function acts as coenzyme A and acyl carrier protein, and requires for the synthesis of steroid hormones, heme and acetylcholine and neurotransmitters. Essential for metabolism of carbohydrate, lipids and proteins. The RDA is 10 mg per day, and the major sources are yeast, eggs and meat. Due to the deficiency, we see burning feet syndrome, which the skin is red over here. You can see on the feet over there. And coming to next vitamin, which is vitamin B6, pyridoxine.
Vitamin B6 pyridoxine. Vitamin B6 pyridoxine, active form. Active form is PLP. Pyridoxal phosphate acts as a major coenzyme in the amino acid metabolism. Biological function is transmission, decarboxylation.
Deficiency manifestation. The first is megaloblastic anemia. Vitamin B9 deficiency mainly causes the impairs nucleotide synthesis. That's why RNA and DNA synthesis halts. The cell cytoplasm grows more than the cell's nucleus. That's why the bone marrow produces abnormally large, immature, dysfunctional red blood cells. That is called macrocytic anemia. Next is cardiovascular impact. The folic acid or vitamin B9 is very crucial in the 1-carbon metabolism, which is halts. When this metabolic pathway is blocked, the toxic homocysteine is not converted into methionine and the usable folate is trapped. This is called folate trap. Next is endothelial dysfunction. High homocysteine causes oxidative stress that damages the blood vessels. Neural tube defect. There are two disorders called as spina bifida and anencephaly. Anencephaly is lack of folate during pregnancy. Here the skull bone grows normally but the brain does not grow normally. Main causes of deficiency, as the vitamin B9 is mainly derived from leafy vegetables and green vegetables. That's why if poor intake of fresh uncooked fruits and vegetable, these deficiency disorders occurs. Next, vitamin B12 or cobalamin. Deficiency manifestation, defective myelination, lack of succinyl-CoA and accumulation of methyl malonyl-CoA lead to the incorporation of abnormal fatty acids into the neuronal myelin sheath. This induces demyelination, affecting the dorsal columns and spinocerebellar tracts. Next is megaloblastic anemia. The folate trap occurs when there is.
Sir, I would like to show the last one thing. Thank you, sir. Thank you very much.
Good morning to my respected professors and my dear batchmates. Myself, Prashant Sarkar from 25-26 batch. I am very privileged to be present here. Let me introduce to my batch group members, Polobi, Rutuj, and Pinak Pani. Our topic is renal function test. Renal function test. Renal function test. Renal function test or kidney function test is a group of blood and urine tests used to evaluate how efficiently our kidney works and eliminate waste product from our body. Kidney functions are following excretory, endocrine, and homeostatic functions. It includes excretory, homeostatic, and endocrine function. Excretory homeostasis, and endocrine functions. And excretory functions include formation and excretion of urine, glomerular filtration, tubular reabsorption, and tubular secretion. Excreting substance from in synergy with liver. Homeostatic functions include regulation of blood volume, regulation of pH, and regulation of serum electrolytes. Reabsorption of essential nutrients. Endocrine function includes erythropoietin, renin mechanism, degradation of hormones like insulin and aldosterone. Vitamin.
Good morning, everyone. I'm Paulomi Shah, roll number 83, and I'll continue from here. We'll talk about the urine analysis. It includes the physical and chemical examination. Here we have the three processes. One, gross appearance. We have to measure here the volume and the color of the urine, and then the microscopy. We have to check the cells, crystals, and bacteria of the urine, and then the biochemistry. We have to check the pH, osmolarity, protein, urea, etc. Then the color of the urine is directly depending upon its constituents. Here we have the three color range: the methylene blue, the pseudomonas, the Riboflavin, etc. And the pink to orange to red. We have to hemoglobin, myoglobin, porphyrins, etc. Then we have to red, brown, and black. We have to hemoglobin, myoglobin, etc. L-DOPA, etc. Then the specific gravity. The normal range of specific gravity is 1.0001 to 1.0040. It increases in the low. It increases in specific gravity in the low water take diabetes increases in specific gravity in diabetes mellitus, low water intake, and acute nephritis, and then the decrease.
Starting from plasma cystatin C, it is one of the latest small weight, low molecular weight proteins that have been only recently considered and found used in case of KFT, and it is also seems to be the subject of tubular handling mechanisms of protein, hepatic protein synthesis, and thyroid dysfunction. Moving on, uric acid is the major product of catabolism of purine nucleosides like adenosine and guanosine, and overproduction of uric acid is maybe caused if there is an increased synthesis of purine precursors. In chronic kidney disease, uric acid is raised, but that is not sufficient enough to cause gout. And although it is seen raised, but raised uric acid is a bad prognostic indicator of chronic kidney disease or chronic renal disease. Both serum and total protein are increased in CKD, reduced in CKD because of increased proteinuria. But acute kidney disease also sees in case of increased reduced total protein and albumin, but it is not sufficient enough to cause a reduction of total protein and albumin. In CKD, we also see hyponatremia and hyperkalemia because sodium is reabsorbed more than potassium, and chloride and phosphate is also increased in CKD, and we see that calcium is decreased because of vitamin D deficiency. Clearance test. Clearance of a substance is the volume of plasma that is cleared of the substance in unit time, and in general we use inulin clearance because inulin is neither secreted nor reabsorbed by the tubules, but this process is usually not preferred. In clinical settings, we use serum creatinine values to calculate GFR or eGFR or estimated GFR. The formula for clearance is given as C equals to U into V by P, where C is the clearance of the substance, U is the volume of the substance in urine, and V is the amount of urine excreted in ml per minute, and P is the volume of substance in plasma. Moving on to creatinine clearance test. Creatinine is an excretory product that is produced because of creatine phosphate, and its excretion is rather constant and not determined by dietary factors or body metabolism. Creatine is filtered through the glomeruli and only marginally secreted by the tubules. The Cockcroft-Gault formula gives creatinine clearance as creatinine clearance equals to 140 minus H multiplied by the weight of the person in kgs divided by the S-creatinine and multiplied by S-creatinine or serum creatinine and multiplied by 72. This result is multiplied by 0.85 for females. Here we have a table of GFR significance that gives the state and the GFR in ml per minute, 1 per 1.73 square meters. We see that the GFR has a clear like a fall as the rate of damage increases. So with minima damage of normal GFR, we have greater than 90 value. With mild damage, we have 60 to 89. For moderately low, we have 30 to 59, and severely low, 15 to 29, and like kidney failure, we have less than 15. I'll hand over the mic to my next team member, Rutuj Deepak.
Good morning, everyone. I am Rutuj Patil and my roll number is 81. So my topic is tubular function test. The function of tubular function refers to the kidney tubules role for reabsorbing essential substances and excreting waste in urine. It also helps to maintain electrolyte and acid base balance. So there are two tests, concentration test and dilution test. So moving forward, first test is concentration test. In this test, the patient is not given food or water after meal at 6 p.m. and on the next day at 7 p.m. the bladder is emptied and specimen is discarded, and second specimen is taken at approximate 8 a.m. Normal renal function specific gravity is should be greater than 1.022. In case of renal impairment, difference can be seen in osmolarity, that is 300 milliosmol per kg. This can be seen in diabetes insipidus. Urine dilution test. In this, patient is not allowed to drink water after midnight, and at 7 a.m. a water load of approximate 1200 ml of water is given for separately for 4 hours. Osmolarity and specific gravity and volume of each sample is measured. For normal readings, at least a patient should have osmolarity of 50 milliosmol per kg, at least in one sample, and specific gravity 1.033 in one sample. This test is more sensitive and less harmful than concentration test. Para-amino hypopuric acid clearance, PAH, is unique as it gets filtered and secreted. The decrease in the level of PAH may signify the tubular damage. So enzymes in urine, they can be helpful in detection of acute renal damage, specifically proximal tubular damage. So some of the enzymes are alanine aminopeptidase, leucine amylase, gamma glutamyl transferase, alpha glutathione as transferase. Enzymes examples of distal tubular enzymes are retaglutathione as transferase, lysosomal examples of lysosomal enzyme, and acetyl beta glucosaminidase.
Good morning, my respected teachers and Good morning, my respected teachers and my fellow classmates. My name is Protoylod, roll number 86. I am here to discuss the aromatic amino acid disorders with my co-partners Pratyusha Mondol, roll number 87, Preeti Roy, roll number 88. Points of discussions: introduction of about amino acids, aromatic amino acids and metabolism pathways and disorders, diagnosis and treatment. Definition of amino acids. Amino acids are the amino acid disorders. Metabolism. The salient features of phenylalanine and tyrosine. The phenylalanine has benzene ring, tyrosine has phenol ring. Essential amino acids. Phenylalanine is essential amino acid. Tyrosine is non-essential.
So we are talking here about phenylalanine metabolism, in which phenylalanine changes to tyrosine because of the presence of phenylalanine hydroxylase enzyme, and here the oxygen changes to hydrogen, water, and tetrahydropterin changes to dihydropterin because of the presence of dihydropterin reductase. Phenylketonuria is one of the autosomal recessive disorder which occurs because of the phenyl metabolism crisis. It is an inborn error of amino acid metabolism in which phenylalanine cannot properly convert to tyrosine because of the absence of phenylalanine hydroxylase, and hence there is issue in the production of rest other products like melanin, norepinephrine, epinephrine, dopamine and thyroxine. The classifications of phenylketonuria are classical phenylketonuria, in which there is absence of phenylalanine hydroxylase activity, persistent hyperphenylanemia because of the low phenylalanine hydroxylase activity, transient mild hyperphenylanemia because of the maturational delay of phenylalanine hydroxylase, and dihydropterin reductase deficiency because of the deficiency of dihydropterin reductase enzyme. Now, first is classical phenylketonuria, where due to the deficiency of phenylalanine hydroxylase, the phenylalanine cannot convert properly to tyrosine. Instead, it diverts its pathway and changes into an alternative pathway where the byproducts are formed like phenylpyruvate, phenylactate, phenylacetate, and phenylacetylglutamine. Because of the production of the formation of phenylpyruvate, it changes. It's a keto acid, and hence the name goes phenylketonuria. Here, mousy odor is found because of the formation of phenylacetate, and hypopigmentation occurs because of the crisis of production of melanin. The other neurological symptoms that also occurs because of the crisis in formation of the neurotransmitters like norepinephrine, epinephrine, dopamine, and melanin is delayed milestone, microcephaly, mental retardation, seizures, psychosis, failure to walk and talk, and also increased phenylalanine and its metabolites increases toxicity to brain. The diagnostic tests of phenylketonuria are FeCl3 test, in which the bluish green color appears in urine, the Guthrie's test, in which a bacterial inhibition assay for phenylketonuria can be seen, and the blood phenylalanine level, which was normally 1 to 2 mg per dl, it changes and rises to 20 to 70 mg per dl. The newborn screening test, which is one of the confirmatory tests, is the tandem mass spectroscopy, and also DNA probes are used. The treatment for phenylketonuria is, if there is defect in phenylalanine hydroxylase, then there is low amount of phenylalanine diet should be used, which is supplemented with tyrosine. Glycomacropeptide should be used, and defect in dihydropterin reductase. To cure that, the treatment used are tetrahydropterin, Kuvan, L-Dopa, and the gene therapy. Over to Preeti.
Good morning, everyone. My name is Preeti Roy, roll number 88. Moving on to next slide. Tyrosinemia type 2, also known as Reisner-Hanhart syndrome, the defect in enzyme tyrosine transaminase, which causes increased amount of tyrosine. It is a very rare disease. Clinical features are like mental retardation, eye lesions, and skin lesions of palm and soles. Diagnoses are elevated level of tyrosine in in plasma and urine, and increased excretion of tyrosine metabolites. Treatments are phenylalanine and tyrosine restriction diet and vitamin C. Then tyrosinemia type 3, which is also known as neonatal tyrosinemia, the deficiency in enzyme para-hydroxyphenylpyruvate hydroxylase, which causes increased amount of tyrosine in premature infant, because the premature liver has limited ability to synthesize this enzyme. As the liver matures, the accumulated tyrosine is metabolized. Serum level decrease within 4 to 8 weeks of age. Now, Alkaptonuria, the first inborn error metabolism to be identified. It is one of the disease of Garrod tetras. The other diseases of Garrod tetras are albinism, Alkaptonuria, cystinuria, and pentosuria. The causes of Alkaptonuria and characteristics are due to deficiency of enzyme homozyntesic acid oxidase. Homozyntesic acid increases, which causes arthritis, black pigmentation of cartilage, which is also known as ochronosis, and the darkening of urine on standing, because homozyntesic acid on standing auto-oxidize to benzoquinone acetate that polymerase to give a dark color, which also known as black staining of diaper. Then Alkaptonuria diagnosis are Freddy-chloride test, urine trans blue-green, Benedict test positive, ammonical silver nitrate test positive, and quantitation of homozyntesic acid in urine done by high pressure liquid chromatography. And treatments are restriction phenylalanine, administration of vitamin C, and symptomatic treatment of arthritis. Now the specialist compound derived from tyrosines are catecholamines. So the tyrosine is converted to dopa by tyrosine hydroxylase, then the dopa is converted to dopamine by dopa decarboxylase, then dopamine converted to epinephrine by dopamine hydroxylase, then dopamine by methylation converted to epinephrine. Now over to Priyogopal.
Hello, my name is Priyogopal Ghosh. My roll number is 89. I'm from 25-26 batch. Moving on to the next topic. It is the actions of epinephrine, norepinephrine. When epinephrine, norepinephrine increases, blood pressure increases, rate of force and myocardial infarction increases, rate causes relaxation of smooth muscle of bronchi. It is anti-insulin in nature. It increases glycogenolysis and stimulate lipolysis. Epinephrine converts to metanephrine by catechol O methyl transferase. A metanephrine converts to VMA, vinyl mandelic acid, by monoamine oxidase. Normal VMA in excretion is 2 to 6 milligram per 24 hours. VMA excretion increased in pheochromocytoma. Pheochromocytoma symptoms is pain increase, epinephrine excess, persistent palpation, neuroblastoma, norepinephrine, and the second is a neuroblastoma, norepinephrine increases. Effects of estrogen on dopamine. Dopa converts to dopamine by PLP, dopa decarboxylase. It decreases tyrosine level. Transaminase activity decreases. Its degradation increases. Competes with PLP. The effects of conversion of dopa, and it converts to dopamine. Its mood variation occurs during menstruation cycle. Dopamine, when decreases, Parkinson's diseases occurs. In Parkinson's disease, neurodegenerative disorder, in 60 years of age of people, its symptom is shaking palsy. Its primary cause is unknown. Degradation of cells of certain areas of brain. It characters is tremors, muscular rigidity, and difficulty in moving over. Giving to Pushpa.
Good morning, everyone. My name is Pushparka Ghosh. Continue from the topic tryptophan metabolism disorder. The tryptophan metabolism has two pathways, chironyl pathways and serotonin pathway. Tryptophan metabolism formed N-formyl kynurenine, help of enzyme tryptophan pyrrolase. N-formyl kynurenine form kynurenine, the help of enzyme kynurenine formylase. Kynurenine form 3-hydroxykynurenine, the help of kynurenine hydroxylase. Then 3-hydroxykynurenine to form 3-hydroxyanthranilate, the help of enzyme kynurenase. Moving to the disorder to tryptophan metabolism, carcinoid tumor, or known as argentephinomas, producing argentephine cells of GIT mobility also help produce serotonin secreting tumor. 60% of tryptophan, normal range is 1 to 3%, is derived to serotonin production, which leads to niacin deficiency, Pellagra syndrome. Autosomal recessive disease discovered in 1950s in London. Defective transport of tryptophan and neutral amino acid across renal tubular epithelium and intestinal mucosal epithelium, defective absorption and increased excretion of this amino acid in urine leads to pellagra, dermatitis, diarrhea, dementia, death.